Hi, everyone. Welcome. I'm Sue Anderson. I'm the president and CEO at Aurora Grande Community Hospital in Marion and French, and thanks for coming today. Sorry we're getting started just a few minutes late, but physicians. Well, I thank Dr. Fowl because he arrived on time. The others are still finishing up office and surgeries and stuff, but they'll be here. But in the meantime, it was funny because today's symposium, I think, is a really good one for those of us that live here in Trilogy, because I've never seen so many hip, knee, shoulder. I know I've had my hip done. I think we're just too active for our own good in a lot of cases. But I'm excited for so many of our physicians to be here today. And I'm going to tell you that the team that you're going to meet today have been trained at great institutions. Dr. Fowl in the back has worked many years with the Olympic team and has gone to the Olympics. He's been a surgeon for our Olympic athletes. Many of these docs take care of local athletes, and they've repaired many of our friends and neighbors here. And today they're looking at new technology that will revolutionize some of the surgeries that they do here. So I want to thank our physicians for attending, and I'll thank them personally when they all arrive. But in the meantime, I want to introduce Amber Rogers. She's our VP of, sorry. Yeah, I forgot to advance that's me, yeah. I want to introduce Amber Rogers, who is our VP of Patient Care Services at Aurora Grande Hospital, and she's going to kind of walk through what our orthopedic program is.
So I'm going to be quick because I have to say I've seen their presentation a few times and it's awesome, very awesome. So I wanted to share right now what the work that we're doing. We are already cutting edge. A lot of the pre-op, before you come to surgery, during surgery, post, and then when you go home, we have a lot of that already in place, those processes and procedures. There's a few things that we need to refine, but for the most part, we're doing really well. So what that means for us as a community is we are going to be applying for advanced certification through the Joint Commission. So that is a certification that highlights the safe and quality care that we provide for joint replacements. We are, specifically, it's called Orthopedic Center of Excellence. What that means is that you're going to have, again, we're already doing this, but it's just going to give us that stamp of approval, decreased readmission rates, quicker recovery, less pain. I'm trying to think of some other things. When you have the surgery scheduled, fewer tests that you're going to need, less expensive. Less test, quicker recovery. These are just a few of our statistics from 2025 through 2026, so a year. We've done 2,049 cases at Aurora Grande. Hips, 144, knees, 274, and shoulders, 33. I was sharing with some of the folks up front that we do we are known for joint replacements. Our team is already, I'm trying to think of the words, cutting edge when it comes to practices across the nation. And so when we look at what we're doing inpatient for all of our patients and community, we're already there. And so we're very excited to celebrate with that stamp of approval.
Thank you, Amber. Thank you, everyone. My name is Matt Bodmer. I'm the regional manager for robotics for Zimmer Biomet. Talked to a few of you as we came in. Sue, you should know, you and your husband have created some pickleball rivalries in the community, so just know that. This is the ROSA knee system. We'll be showing off our new version of ROSA called ROSA with Optimize. So this is meant to increase efficiencies for the surgeons and provide better care. So robotic total knee replacement, what is it? What we do with Optimize is we're able to personalize the approach to total knee replacement. We use the data collected before, during, and after surgery to be able to optimize how the surgeons are preparing care. So everyone's different, whether you're a pickleballer, I'm a big skier, so I would like my knee a little bit tighter as I'm in flexion. They're going to be able to create personalized profiles on the robot to treat each patient differently. And they're going to know right when you walk into the office what you want to do, how you want to be acting and active after your surgery. They're going to know that and have a profile built for you in the robot. So the optimized differentiation, the optimized planning, which I was just talking about, optimized landmarking. So I think it was either Sue or Amber was talking about how with the new center of excellence that you're building, it's going to make the total episode of care less expensive. This robot right here does not require any imaging. So you can get an X-ray so they can basically pre-size what your implant's going to be, but it does not require a CT scan, does not require any kind of preoperative imaging. We go right here. Some of you may have seen me setting up the sawbone here. We just go through, take 14 points on the femur, 8 on the tibia, and then we're able to start the surgery. So no additional imaging needed. I like it. Yeah, round of applause. The dog's still sleeping, but it's okay. We'll wake him up. So this is kind of what I'm talking about on Zimmer Biomet and the technology that these surgeons are going to have access to. They're going to be able to use data and real actionable results based on what has worked in the past to be able to apply that to your surgery right away. And when I talk about the automated planning, I'm hoping that the next slide has the video that works, but if not, I can show you on the smaller screen up here. Do you see the little yellow box there? That's where they're going to be able to select their personalized plan to you. And there we go. They're going to click it, and it's instantaneous. They're going to be able to plan your knee to well balanced instantaneously. So this is something that in previous versions of the robot would take, I don't know, 1.5 minutes, 2 minutes, which may not seem like a long time, but in an orthopedic surgery, it seems like a lifetime, 2 minutes sometimes. So this is now going to be instantaneous. And that's it for my presentation. I think Dr. Fau could do more talking than me, but I'd be happy to answer any questions if anyone has any. Yes, sir.
How does this compare to?
Oh, sorry. The sir behind you, sir. You're next, I promise.
How does this, what you're doing compare to the cadaver knee replacement and the nano knee replacement? Was yours different than the nano knee?
I don't.
Yeah, I think that would be more of a Dr. Fau question.
I mean, this is a computer-assisted joint replacement. I'm not sure what that would be, but so this one, I mean, we're using this is probably one of the most commonly implanted knees in the country. It's got a very long track record. So I think with this, what we're doing is we're kind of blending, what this implant or this machine does is it helps us more accurately cut. So instead of using calipers and using goniometers, this will actually find the exact center rotation of your hip, how your knee hinges, whether you're knock-kneed, bow-legged, and then it gives you a best prediction of what cuts should be, and it helps guide you through the cuts, and then you put in your implant. And then there's, afterwards, then you have, afterwards you can have things like mind mobility where I can track you. I think as time goes forward, we're finding that, we're trying to be more efficient in healthcare. But at the same time, technology is letting us get a little closer together. So we can now have an app on our phone or computer. We can see how well you're progressing at home. So you take the information you get during the surgery with the robot, all the little subtleties of what it's suggesting and how accurate we get our cuts, and then how well did you do afterwards? What's your motion like? What's your pain like? And we can probably tailor things and fine tune them as time goes on, and we kind of learn from it. So we get better and better as time goes on with this kind of technology. It's pretty impressive. So I think, what you got is none of us are changing the implants we use. The robot kind of allows us to use the same implants we've always used, and then makes everything a little bit more accurate. And so we're still familiar with the implants, but we're moving ourselves forward in technology.
And you were asking about a cadaver knee, was it, as well?
Yeah.
Did I hear that? I don't know of anybody who does a cadaver knee. There have been fragments of bone and cartilage that are implanted, and they don't work very well. They're about 80% take on each little piece, and that's just a small fragment of the whole knee. So nobody really implants a complete knee. Cadaver parts are for younger people that have broken little pieces of cartilage off, or meniscuses that are torn, or ligaments that are torn. We replace them with cadaver parts sometimes. Oh, I'm sorry, we don't want to hurt anybody's neck. We were thinking of going up front. And you asked about another copyrighted name of a procedure. Don't quote me on this, anybody here, because whoever possibly invented that, theoretically, that name happened to be a partner of both Dr. Fowl and I. So we may have inside information that we shouldn't share. But let's just put it this way, it's more sizzle than steak. This is all sizzle as far as high technology. And the other one sounds pretty cool, but
Why don't we
if you want to
real
ask
quick,
anything personally to either of us in private about that, we'd be happy to say it.
why don't we quickly have both of you introduce yourselves, and when the other physicians arrive, they can do the same, but just tell a little bit about your background.
Hi, I'm Mark Weiss, orthopedic surgeon. I've been in the area since 1999, and I practiced in St. Louis, Missouri prior to that. My original background was more in sports medicine, but as I progressed, I probably do a lot more joint replacements than ligaments. Can you hear me? I'm sorry. And I'm in private practice now, solo practice. Not the busiest guy in town, but I try to do a good job with the ones, everybody I take care of. Still hard to hear? Wow. And just my former partner, Dr. Fowl.
Hi, I'm John Fowl. I've been here since 2003, so a little bit after Mark. I too was trained in sports medicine, and I think as we found that, and actually the professor I trained with was with Mark. So actually,
Oh, yeah, and
so we do.
Dr.
He was-
Sadami.
That was one reason I came, because he was so well regarded. So anyway, I think what we found is with sports medicine is people age, athletes age, they wear things out. So whether it's a shoulder, knee, or hip, these replacements are much more common. And the sports guys that I trained with did a lot of joints. We usually get 150 joints a year just with each sports guy. So I think the sports guys end up getting busy as we get more mature and do the joint replacements for the patients that we try to preserve the knees and hips and shoulders.
Yes, sir, and the Yankees.
What's the typical recovery time? Is it, do we have to spend overnight in the hospital or days or go home immediately?
That's a good question. The trend lately has been to do more and more joints in the outpatient setting, even in an outpatient surgery center. I would say that the majority of my patients have medical issues that maybe that's not a great idea. If they've got cardiac issues or pulmonary issues, that maybe they should have a little bit more observation, because a knee replacement or a hip replacement is, not as big as a heart operation, but it's a big enough operation that you might want to keep somebody that has medical issues under observation a little bit longer. However, doing it as an outpatient has a lot of advantages. You're under your own control. You don't have to wait to take your pain medicine and that sort of thing. So I guess either or. A lot of people, even at the hospital, if they're doing well, they go home the same day.
Yeah, I think I take that approach. It's more, I just want to make sure people are safe to go home. So I want to make sure people can walk 50 yards, 10 steps up and down, and transfer by themselves. So I feel like once they can do that, they're safe to go home, whether it's the same day or the next day or the following day. And I think I like the resources of the hospital available in case there are problems or itches, people are dizzy, nauseous, or need a little bit more TLC. So, I'm just biased that way, but I do all my cases at the hospital, in the surgery center.
I just want to give it, I can't talk very loud, big hand to Dr. Lewis. 9 years ago, I had to have both my knees done. And I went to him, and he was just doing it, I don't think for very long.
It's on, you just have to hold it.
So I went to him, and he said, well, we can do the partials. And he said, but I have to do one at a time. I said, no, you can't do that. I have to have them both done together, because I'm an athlete. I like to play pickleball and golf and everything. And I'm having both of them done. So he agreed. Went home. 2 days later, a physical therapist came to my house. And when I answered the door, he says, I'm here to see Sandy Hartley. She just had her knees done. And I said, that's me. And he said, no, it can't be. She wouldn't be walking. I said, you want me to dance on my floor here? He didn't come back, I think, one more day, and then he didn't. And my knees, I play pickleball. I'm 84 years old, and I can beat up a lot of these people here. I'm a hockey player to do it, so I had to give up golf and tennis because I was really nervous about in tennis, the knee spreads out. So I gave that up. But thank you. And your wife, she's the best person ever.
Well, I agree with you on that one.
Thank you so much.
Thank you.
Okay, we have some questions too, so I'll throw in there. We'll go along with the pickleball theme, but so one of the things I hear around here is I'm a pickleball player and I have a nagging knee or shoulder issue. When is it time to visit an orthopedic surgeon? Oh, and we'll let Dr. Costello introduce himself.
Sorry I'm late. These guys are too good looking.
Can you just introduce yourself and talk a little bit about what your background is? Okay.
Paul Costello, I'm an orthopedic surgeon and practice principally in Santa Maria. I've been there since 1998. In a big group of 12 people, but I've known these two very fine gentlemen, excellent orthopedic surgeons next to me for a while. I got to know them better recently. I've been doing total joints, for 30 years, and there has been a big evolution in that change of how we do them. So I'm enthusiastic to be here, and I'm sure you've been told by these two why we're supporting getting a robot and making more predictable and reproducible outcomes. I barely heard that question, but we do encourage people to play pickleball because it's like an annuity for us. Please continue to play. I'm sorry.
So the question is, when should they come in to see an orthopedic surgeon if they have a nagging knee or a nagging shoulder or?
That's a good question. We all have problems that would be beyond nagging. I mean, I would say if it's a lower extremity thing that hurts just to walk and you're having swelling in the joint and you are having difficulty pivoting and rotating, getting out of a car, out of a bed, that's something you shouldn't ignore. I mean, that's something you should go see somebody about. There are things that, you could just treat normally with just modifying what you're doing, icing, elevating, using some over-the-counter, anti-inflammatory medications. Upper extremity injuries are a little trickier because the ball and socket joint of the shoulder can have significant problems without kind of recognizing it. You don't really have a loss of function, a loss of range of motion until late in the game. I think if you fall or you have an injury in which you impact both, either you twist and land and hurt your knee or land with your outstretched arm, and then have symptoms after that, you should probably come see us.
Okay, one of the questions we got in the box was, what do you do when your meniscus is torn and you're told the surgeon can't do anything till it's bone on bone? Do you just wait 5 to 10 years?
It kind of depends on the type of meniscus tear and whether it's repairable. Sometimes you can repair a meniscus tear, and the consequence of that is you have to spend a lot of time on crutches while it's healing. So sometimes weigh the pros and cons of doing that. If you've already got some arthritis in the knee and you have a degenerative meniscus tear, which may or may not have been from trauma, repairing that meniscus might not get you any better than you were to start with. So I guess it depends case by case whether or not you should have it repaired or just live with it until it gets bad enough to. If you get a partial or a complete knee replacement, you can put your weight on it right away, and in most cases do very well quickly. Whereas with the meniscus tear, the outcome is uncertain if you repair it. If you've already got arthritis, that's probably going to progress anyway.
There's a question. I'm coming around with a mic.
There. Thank you. You mentioned partial knee replacement. What is the condition of your knee have to be to qualify for that surgery?
In general,
Thank you.
if you look at the long-term success of partial knee replacements, I mean, I think one of the stated rates we have is a 10% failure in 10 years, whereas total knee replacements might be 3 to 5. I mean, this is how good knee replacements are. I mean, if it's more than 5% fail at 10 years, it's recalled, and they stop selling them. So these are very successful implants. And then, I mean, look at Lindsey Vonn. I mean, Lindsey Vonn had a partial knee replacement. She tore her ACL, and she's going to try to compete. She probably let someone else do it. So I think it's very hard to compete with a cruciate ligament injury. So let's say you get a partial knee replacement, you have to have the other parts of the knee nearly perfect, no meniscal damage on the other parts of the knee, and you have to have a stable knee. You can't have an ACL tear, PCL tear, or ligament injury. So it's a very select group of patients that are really candidates for partial knee replacements. We still do them in a certain patient, but you know, things can happen, and 10% of them have to be converted to totals on average.
What happened? 9 years.
Wow.
You mentioned ligament tears. When you do a total knee, what happens to the ligaments in the front of the knee?
I'm sorry. What happens to the ligaments?
Yeah.
There's different types of total knees. You can have a ligament sparing type, which we don't take the posterior cruciate ligament. You can sacrifice the posterior cruciate ligament. There's different kinds that we use, and some people have preferences, and there's some reasons why we would do a sacrificing and why we would do a sparing. So you keep the collateral ligaments, but you always harvest, or not harvest, you always sacrifice the ACL. So the posterior cruciate is the one in the back. So we generally, there's been some, I don't know if that's even still in the market. There was some, they were sparing all the, 2 cruciate ligaments. And I don't think the results of that were predictable or good. And they had a lot of manipulations, a lot of revisions. So I think principally you're going to have a sparing or a sacrificing joint replacement. And they're generally equivalent when you look at the outcomes of those, 10 and 20 years. You just want to have a surgeon that does it all the time, and that's how he feels comfortable doing it. And you have a knee that matches the surgeon's, preference and skill.
Yeah, it's interesting because way back in the history of orthopedics, before they had modern joint replacements, they had a version where it was.
Is that when you trained?
A bilateral. Yeah. This was kind of like when the Civil War was around. They had a medial and a lateral partial, and it didn't do very well. But it's funny how things evolved. And then what Dr. Costello was saying, they tried to do a bicruciate retaining component where they spared both the anterior and posterior cruciates because, anatomically that is more correct. And that's why a partial knee replacement usually gets more range of motion. You can usually get to 140 degrees with a partial, whereas it's very difficult to do that with a total. You have to make some compromises because they always take out the ACL. But these, I think 2 vendors had bicruciate retaining, and they're both off the market as far as I understand now. They just didn't work. It's too hard to balance.
Okay, Dr. Spoo just joined us, so why don't you go ahead and introduce yourself?
Is this on? Yeah, Jeff Spoo, Central Coast Orthopedics. I just got out of the operating room. Looking forward to the ROSA.
And you've been in practice how many years?
Oh,
Have you been in the area?
I've been here 23 years. Yeah.
Okay, here's another one, another question. Oh, there we go. Okay, here's another question. Is there a procedure where cartilage can be taken from the body, sent to a lab to be grown, and then replaced back into the body, such as a knee, so there is no need for knee replacement?
I'll take that since I developed that in the early 90s when I was in the Army. So that's called if you have a traumatic defect where you knock a chunk of cartilage off, let's say you have ACL injury, and you do knock a chunk that's a full thickness loss of a portion of the weight-bearing part of your knee, that can be reconstituted by going in and taking cartilage from an area where you don't weight bear, grow it in the lab and wash it for, I think it's Massachusetts, and then they impregnate it onto the back. They take the cells that they grow for 6 weeks and put it on the back of a cow tissue patch, and then we patch that on there. It basically regrows your cartilage. That's for not bipolar, not two-sided arthritis. So there isn't a procedure where you can go in and take cartilage and grow cartilage and then put it on both sides of the joint. That does not work. So it's really for a traumatic defect that you could be 50, have an injury, knock a chunk of cartilage off. It's not as common as a younger, 20-year-old that does it. But yeah, in that strict way, you can do it, but it's not for a bipolar, both sides of the joint arthritis.
Because arthritis is more of a, it's not just lack of cartilage, it's altered structure to the bone. It's kind of if you have a car and your wheel's bent, you put new tires on, you're not going to drive well anyway. You need new wheels.
Okay, next question. Oh, were you going to say?
Well, I could add some about it.
Yeah.
But what Dr. Costello was saying, that might work temporarily in a young person who's had something like a pothole on very normal cartilage. I think of it as like a pothole on the road. They patch it, and it works for a while, but then, several heavy trucks drive over it, or if you live in the Northeast, the weather gets in, and eventually that breaks up. What fills it in is still, even with those special cells grown in the lab, it's not normal hyaline cartilage. It's fibrocartilage that looks a little bit better than what we used to call marrow stimulation, just drilling holes in the bone and letting it fill up with blood. That's still done, and it works almost as well as that Carticel technique. But when you have arthritis in your knee, it's not a pothole. It's like the whole road has been scraped clean of tar, maybe except for the very edges. And if you try to patch a little pothole there, it's not going to work at all.
I mean, there's the other method, like if you look at return to sport, what we're talking about is microfractures, where you do marrow stimulation, you poke holes in the area where there's a defect, kind of forms like scar tissue patch. And then you have MACI, where the Carticel implants, where you send it off, get it grown, and you put that little patch in. Those are for potholes, like ROSA. So there's other ones, de novo, which is actually, I've done a few of those, and those are actually Carticels from fetus. And so that implants and grows, that's a little controversial, but that does work too. But if you're trying to get hyaline cartilage, which is the normal cartilage of your joint, as opposed to fibrocartilage, and sometimes it's just very hard to do. There's actually return to sport was highest with what's called Oates procedure, where you take, it looks like an apple core, and you take little plugs of bone and cartilage underneath, and you plug those in almost like a mosaic, like your sidewalk, and then that little patch for a defect is actually a higher return to a higher level activity than some of the other stuff. And then the other thing about the cartilage patches is, you look at the actual protocols for it, you're supposed to be low activity for 2 years. But the guys that play soccer in Europe, they just go right back to it. And a lot of it was catered to those athletes like that. And they'll do anything they can to maintain or keep playing.
Okay.
Can I ask a question?
Yeah.
Do you guys do revisions? In 1996, I had a meniscus tear and a lateral release that turned into 5 knee replacements, 5 infections. The last doctor removed my knee totally and fused my leg from my thigh to my ankle with a rock. And I play pickleball, I play golf, I ride a bike, but I can't bend my leg.
So it's completely fused.
Completely fused. And I had CRPS.
That's awful. I'm sorry. That's like one of those disasters that
I've done
happen.
it, yeah.
A knee fusion is your only salvage. If you're doing what you're doing, don't come and see us. Because pretty well, you're functional, but you can't bend your knee, and there's no salvaging a previously infected knee that got fused. So that's.
May or may not have your ligaments there. Yeah, you end up being, you're more of what we call a teaching hospital case, where you'd see the guy that sees the worst of the worst at USC,
Right.
UCLA, Stanford, something like that. So usually, we kind of pick and choose which cases are the best for us, and which you need to see somebody who sees a lot of zebras. We
Right.
see a lot of horses, and then if we see a few zebras, and sometimes there are zebras, but sometimes you want somebody who sees a lot of them and has good experience knowing what will help you and what won't. And so that's somebody who will give you that good opinion.
I was wondering about the anesthesia. Does it have to all be done in general anesthesia, or is there another way to do surgeries?
Jeff, why don't you get that?
Well, you need anesthesia. You don't want to feel it. But they made a lot of advances. We used to have indwelling catheters, and the patient would be in bed for 2 days, go to the bathroom, be in the hospital for a week. We're going more towards spinal and regional blocks and infiltration and medications that cut down the bleeding and medications that cut down the anti-inflammatories. It's more of a multimodal anesthesia. So now my patients are going home the next day, most of them. Some patients are going home that night. I like to watch them the next morning. But I think the anesthesia makes a big difference because the faster you start moving, the faster you get up around, the better you're going to do. If you're not moving, you're going to get stiff, you're going to get manipulated and things like that. And so, yeah, I think and orthopedic technology has improved, but I also think the anesthesia is an important part of the team, and that's really made a big difference.
So standard now is not general. Okay, it's a spinal, and you get an adductor canal block, so it blocks the sensation in the front. General anesthesia, you have a lot of side effects mentally. It takes 2 or 3 months to recover. Your mental status, for a lot of people over 70. And you also have urinary retention. You have all these other things that go along with general. And most people are done with a spinal and a regional block. But not everybody can have a spinal. Not everybody gets a successful spinal. Very unusual. But we try to avoid the general because it's hard to walk the day of surgery when you're recuperating from that. And plus, you don't have to put a breathing tube down into your trachea, to breathe for you. So you're just getting oxygen through you're mostly under kind of an anesthetic where you're getting some sedation, like you're going to get a colonoscopy or something. You're kind of out of it. You don't really realize what's going on, but you're still not getting put to sleep. So that's kind of the standard.
Good question. Okay, can you talk about hyaluronic or rooster GD treatments? When does it work rather than surgery, and how long does it last? Is it for everyone?
Well, our academy officially has said they don't recommend that anymore, but I still do it. It's been around. In humans, they authorized it in 1997, so it's nothing new. Hyaluronic acid is two sugars that are chained together in a long molecule. It's found in virtually all mammalian species. It lubricates the joint. You find it in your skin, and it tends to get depleted as you get older. So it seemed to make sense, since there was less lubricant in the joint of arthritic people, to try to put more in. They also lately have developed longer-acting artificial hyaluronic acid, if you will, these single injection formulations where it's not natural, where they take the linear molecule and cross-link it, somehow jumble it up so it's very viscous and it'll stay around longer. But that's not natural. It has a higher incidence of pain afterwards and allergic reaction. So anyway, I do the 3-shot version where you do it 3 shots every week. And some of the studies lately have said, well, it doesn't really work much better than placebo. And no insurances will pay for it anymore except Medicare. Medicare is a big question. So that's where we stand with hyaluronic acid. It's not a miracle, but I do still have patients that respond well to it, and Medicare will allow it.
Is it a Band-Aid before you really need full surgery?
It never gets rid of your arthritis. So it doesn't grow new cartilage, even though hyaluronic acid is found in the structure that is part of the backbone of not the collagen, but the ground substance that absorbs water into the cartilage. But I don't know that the hyaluronic acid that's injected actually gets resorbed into your cartilage and incorporated. So the other interesting thing is glucosamine that you see on the shelf. Why do people take that? Because that's a component of hyaluronic acid. It's one of the 2 sugars that chain together. But when you eat glucosamine or hyaluronic acid, chances of it getting into your joint in the first place and then get incorporated into cartilage pretty soon.
I would give you also just if somebody can't have surgery and they're 90 or something of that nature, we do anything we can to help them. So it works in some populations, but it's not something if you're going to have, the reason the academy pulled back from it, it doesn't change the natural history of arthritis. You're going to have a knee replacement anyways if you have advanced enough arthritis. But it has its role, but it's not paid for by hardly anybody. I'm surprised. I mean, Medicare pays us less than it costs us to buy it. So usually we have to have you guys get it through some pharmacy somewhere else. I would tell you any, I'm surprised that we haven't heard, we're here about robotics, but we're going to get to that, right? I can't wait.
You missed that.
Oh, did I miss it? Damn it. No. Well, other things you'll probably, I'm surprised someone's asking about stem cells. There is no such thing as stem cells in this country. You have immature mesenchymal cells, and they can be obtained through your fat in the highest concentrations. They are poorly concentrated in bone marrow, aspirate. They're poorly concentrated in fetal, or the blood you get from the cord. You really have to do basically a liposuction to get it. And they're not allowed to concentrate cells in this country like they can in Bogota, Colombia, South Korea, and Germany. And there's American companies there that do that. So it's like throwing a bunch of little seeds out there or a billion seeds. So all the pro athletes go to those places to get it done. That doesn't show any difference and make any difference to change the architecture of collapse of a joint. So if you've collapsed your joint, there's not going to be any improvement and restoration of that joint space by putting stem cells in there. There's a lot of people in this country that get sort of duped into using stem cells. I'm not going to blame a certain population, but it's not physicians that are generally doing it. So you get people that only show you a picture of an x-ray that shows a collapsed bone-on-bone joint space, and then they have this other picture that shows the joint space is normal just because they got a stem cell. And oftentimes these injections are given by providers that are using steroid injections, so people feel good. They feel good for about 4 to 6 months, and then you got to come back and have another $10,000 stem cell injection. So beware. And if you want information that's reliable, don't go to the internet just blindly. Go to Ortho Bullets, like the gun bullets. It's going to be the top 4 selections in Google that covers. If you put rotator cuff tear, you put knee arthritis, you put the first thing you'll see is Ortho Bullets. Go to that, and the top selection usually gives you an outline. It's what I use. It's updated every month. So it's evidence-based, peer-reviewed. So if you want information that's reliable, that's what I would use. And don't just go to a blind website, because the top 4 selections are usually sponsored. So those are somebody that's going to try to sell you something, but they're occupied by orthopedics.
Hey, Joe, you have a question.
Why is robotic surgery better than using human surgeons?
I just came back from a big course, and I'll just, there's not going to be anybody that can tell you robotic surgery is going to make everybody's result better. But it clearly will make it much more reliable, much more predictable, and it's not eyesight determined. 20% of people that get total knees are unhappy. It doesn't matter if they have good x-rays, they have decent motion, they're unhappy, they have pain. And we always attribute it to something going wrong with soft tissues, like it's your hamstrings, it's your IT band, it's something. It's oftentimes because we just didn't get it right. And and it's not the fault of the surgeon, it's a fault of the ability to get the position of the components in the way that you need to have them positioned. So 20% is pretty high. We don't do a lot of things where we fail 20% of the time. We like things that fail 5% of the time. So it has its evolving role. It's been difficult to show a difference, between outcomes of patients' reported outcomes and our measurable outcomes. Because 80% of the people are so damn good, it's hard to show a difference, okay? But that's at 5 years. Now at 10, 15, 20 years, I think there's going to be a difference. It just, and it does take a very limited learning curve on this. This is a very easy thing to use. Reproducible, doesn't take as much time as the Mako. It's just not as difficult and occupying so much space in the OR with all these. It's an easy robot to use. So if you want some reliability and you want some dependability and you want some reproducibility, I think that's kind of what I know by my eye. I think I'm pretty good, and I think these guys are excellent as well. We get our x-rays afterwards, it's not always perfect. So there's anatomy difference between each individual. So I would lean towards using technology when it's available to us, that's easy to use, that's not going to cause complications, not going to provide a greater risk of infection, and most likely is going to give you a better outcome.
The other thing is, I don't want you to have a misconception that the robot's doing this. It's not. So I think what this robot does is you're putting an array like they have in Avatar. They have a little bubble sticks on. So you have a little bubble array on your tibia, bubble array on your femur, and then that's within the incision for the total knee replacement. And then it analyzes the rotational axis, the anatomic axis, of the patient. Then it helps guide you in the two cuts, the first cut of the tibia, the first cut of the femur. That's what it's doing. It's the analysis that's more accurate than our eye or calipers or goniometers to measure those things. And then it helps us predict and modify with all those, with that software, how to use that information to make that best first cut of the femur and the best first cut of the tibia. Then once that's done, we go back to the same stuff that we use to do our knee replacements today. So it's not doing the surgery, and right now, even though Elon Musk says it, there's no robot that's going to be able to do this surgery for. So.
Another concept that's a little bit more difficult to explain, but the way we look at the way the knee is aligned is kind of static. You're looking to see how it looks on the X-ray, but that doesn't tell you how tight it is. Is it going to be the same when you bend it versus straighten it out? And there's various ways to try to make that even out so that the knee will bend well and not be tight in either flexion or extension, but none of them are perfect. And there's one trend to balance it after you make the cut. Loosening ligaments, they even have an implant that you electronically can tell if there's too much tightness in flexion or extension after you make the cut. With the robot, you can do it all beforehand and test the tension in the joint in various degrees of flexion and use that as information. Well, maybe I shouldn't cut it the way the X-ray said I should. So I think it helps.
I'd also say it does depend on the implant you use. And this implant that they have has been on the market for over 30 years. They have the best plastic. It has the slowest wear rate in all of the studies. And then it's the plastic that is really the rate limiting step. You don't get the implants in the right, they're not just the way they should be. They put excess pressure on one side of the joint and it will get excessive wear. If you have poor quality plastic that isn't processed correctly, I would say correctly, with a certain technique that they use that's without oxygen. So it's very technical and it's highly cross-linked. So they last a lot longer. Like the implants are probably gonna last 25 years now is what I'm kind of seeing projected out. So you want to try to put off for as long as you possibly can, just endure it till you can't stand it. And then you get it, so have it done one time. These guys want you to have it several times, but you don't want to have a revision. So it does make a difference with one implant and what kind of plastic is being used.
There was a question over there, and while we're getting a mic to you, or you have a mic, there was a question about if any of you also do back cases, and I know in Central Coast Ortho you have an ortho spine special, two of them. So within the group you do. I don't know if anybody wants to comment on backs.
Jeff.
No, but you do have two.
So we do. We have two very good orthopedic surgeons that are, one of them just joined the group about 5 years ago, Dr. Sabatino, and then Dr. Blackburn's been in practice since '99, maybe. He came a year after I have, but he's got a lot of experience doing spine. So they both are well trained. And, there's differences between neurosurgeons and orthopedic spine surgeons. But I think if you have a problem where you have leg or arm pain, and you have numbness and tingling with it, and you have weakness, then that's the time when you really want to seek out a surgeon.
Okay, over there, question?
Hi, I'd like to know if Medicare covers the robotics component of the procedure.
Yeah, I can probably answer that. Medicare pays us based on what you're having done. So if you're having a knee done, we'll get the same payment whether it's done robotically or not. So it's really more it's less about reimbursement and it's more about the outcomes for the patient.
Yeah, we will not get paid anymore It'll take us a little longer, but at least the hospital, Dignity's got the willingness to participate in bringing in technology that can make us better surgeons and better outcomes for patients. And we're gonna need help with foundation participation, with donations to get it. But this is how, at least you have a hospital that's willing to do this. Most of these things are done at like tertiary centers where, it is a good thing, I think, to kind of keep on the evolution of technology. You don't want to just jump in right away. So there's been plenty of evidence of reliability, better outcome. It just isn't being able to show a huge difference to the point where they're going to pay you more. So they don't get paid any more money. In fact, they're going to get paid less money because it may take a little longer per case, and they won't be able to do as many cases. But if you don't do this, you're falling behind. There's only one I think there's one in French. There's only one robotic right now in the Central Coast. And there's another person in town that does a certain type of knee that is not robotic. It's just getting a CT scan and getting a patient-specific type knee, but it's no different than the knees that we do. But this is different. So this is different. This does make it attractive to patients to come to this place, have their knee done.
I like what you said about, taking your time to really invest yourselves in what you want to use, because we did have a robot at AGCH years and years ago, and it really wasn't used much. It collected dust. So it's good to have all of you in agreement on the equipment that you want to use. I had a question here. How long must one live with severe paralysis from lie compression until seeing an ortho doc?
What was that?
Here, I'll let you.
That sounds like it goes to Dr. Spoon. L4.
This is how long must one live with severe paralysis?
No, that's in team.
I think you should see someone right away.
My question is, what's the cost of that machine, and how is it disinfected between uses?
So I believe the fundraising goal for Aurora Grande is $600,000, I think is what the cost is currently that we're raising for. As far as sterilization, there's a sterile drape that goes over this, and that's removed obviously after every case. Just doesn't look pretty in the room, so we didn't bring it today.
Matt, could you also talk about how it's produced?
Yes, sir. Yeah, so the arm itself is made in Montpellier, France. Our robotic headquarters is in Montreal because there's a very high-level engineering school there. And then it's assembled in Warsaw, Indiana, where ZimmerBiomet headquarters is. And then final packed and shipped out from Mississippi currently. So it goes on quite the journey to get to you.
Can you tell us what the difference is between this and the Mako? I had a Mako knee, so I'd be interested to see the difference I would have experienced.
Yeah, absolutely. I worked for Mako for 4 years, so I've been in a couple thousand of those. The main difference is the CT scan that you need prior. This involves no pre-op imaging required. Secondarily, I think Dr. Fau was talking about how the two cuts that we make are the distal femoral cut and the tibial cut are what are made robotically. And then we're setting the pinholes for the what we call the 4-in-1 guide to make the rest of the cuts on the femur. So we believe, and I have seen, that it introduces less cuts in between, less hair in between the cuts, because the two cuts are made robotically, and then we're putting on a fixed block for the other 4. So there is no robotic margin of error between those cuts.
But how was your makeup?
I have a 140-degree bend, so the guy said, come back and see me in 25 years, I'll do a replacement then.
I told you, 25 years, man.
So you got a partial knee?
I'll be dead by then.
Partial knee?
Sorry?
Partial knee or total knee?
Totally.
Okay, nice.
Is this for hips too?
We do have a hip application. It is direct anterior approach only. We also have a partial knee application, and we expect total shoulder to be out middle of this year.
ROSA being used now, or is it in the future?
Yeah, absolutely. So ROSA knee was launched in 2019.
But I think she's asking too.
don't have it yet. Not yet. Yeah.
Oh, okay.
But we're very close.
Very soon.
Okay, so what's the time frame? Do you have one?
Sue and I will be talking directly after this meeting. Stay tuned, it'll be televised.
No, we hope to get it in place very shortly, and that's why we're taking the show on the road to show the community what we're trying to do and ask for support to get this there. But we're well on our way to bringing it to the hospital, so hopefully within the next few months. Get a microphone.
What kind of imaging do you use to create these points of reference?
I can take that, yeah. So there is no image that's required. So like right now, I can just kind of show you how we do it. So for one of the landmarks, I'm just getting the femoral head center, which gives us what we call the mechanical axis of the knee. And so right now, the camera is just looking at these blue trackers I think she was talking about earlier. And so there is no image. We're just in real time getting the patient's real life points on both their femur and their tibia. And then to the surgeon's points earlier, we're going to evaluate their soft tissue and then be able to make all the cuts from there.
So it's photo imaging of the lines.
Yeah, I mean, it's infrared tracking. So basically what it's doing, what the computer's doing inside is it's making a bone model in real time. So we get all relevant points and axes. So anything that they need to be able to balance the knee, we're creating essentially a bone model and an algorithm inside the computer in real time with these trackers. Before any cut, yep. After incision, before cuts.
I'm not sure I understood it correctly, but it seemed like at the beginning you said that the recovery is faster using this technology versus just a manual operation.
Do you want me to take that? I mean, we do have research that suggests that. Go ahead.
I just think it just looks at it, the more balanced your knee, you're looking at, like we had said, about 80% of people are happy quickly, 20% need more TLC. We're trying to reduce the amount of people at 20% to make that more and more successful by having a more accurately balanced knee. This also, the technology kind of dovetails into, after you've had the surgery, rehabilitation, so we can kind of keep an eye on you. And then as time goes on, as we look at how well you rehabilitated and what we did in surgery, that helps us refine what we're doing in surgery, so it gets better and better. So this technology ultimately will probably make it easier for you to get through your recovery. And I think we're going to have a little bit more of our finger on the pulse of your recovery with some of this technology too. So you may end up having, apps like just like you check on your pacemaker, we're going to check on if you're getting your motion, if you're doing your exercises 3 times a day. So instead of having a therapist go to your house 3 times a week, we're going to keep on you a little bit tighter. So we're going to be driving you forward. We sometimes need a little bit of a cheerleading to keep moving, take a little bit of pain, get your motion so you have a good, successful outcome.
But what you're saying is
we can put a sensor in your knee. It is one of the technologies that they have.
So what you're saying, the recovery is the recovery faster?
So, I mean, it's a little bit of a jaded question there. It depends on people's status of their knee before surgery, their overall health, their deconditioning, their status of like whether they have diabetes. There's a lot of things that go into recovery. But I would say overall, if you get a knee that is well balanced, you should be able to recover your motion. I can tell you that there hasn't been studies that have been showing differences in range of motion and recovery rates in those 80%. It's the 20% we're looking at. Okay, so there really is, but long-term recovery, long-term, sort of longevity of your implant's performance is definitely something that I think will be better. I don't know that, but I think most people think that, but we just don't have longitudinal studies long enough. So you're looking at 5 years, and now they're starting to see differences at 10 years. So, I mean, it's hard to answer your question. I don't want to say, hey, you have a robotic knee, you're going to be recovering way better than your neighbor. So.
Was there a commitment to physical therapy after the surgery that had some correlation with your performance?
There is no doubt. It doesn't have to be physical therapy formally. There's plenty of studies that do home therapy, but there's not a lot of people that's willing to put themselves through death, is what it takes to get through that first 2 weeks. It's horrible. The first 2 weeks are tough. I don't care what anybody tells you. We don't cut the tendon. We go for all this stuff. It sounds, like it's super easy. It is not. It's very difficult. And you have to have multimodal pain control like Dr. Spoon. You're using an ice machine, you're using an anti-inflammatory, you're using narcotic, you're using all these different things. But you have to do stuff and push yourself to get your motion quickly. Because if you get stiff early, you're not gonna do it. You sometimes have to even have manipulation. But I think all of us still use formal physical therapy. There's plenty of pushes to not do that and just do home exercise programs. And there's been results similar, but I'm just telling you, it's very difficult to push yourself. Getting up and getting into a car and driving somewhere and getting up and moving around, that actually has a lesser chance of you getting a blood clot and a pulmonary embolism. So there has been recent studies that actually going somewhere and attending therapy gives you sort of an unanticipated benefit.
And is there any preparation ahead of the surgery that you do in that vein?
Typically we used to. I know you guys we used to send people to physical therapy ahead of time. We don't do that.
I feel like a lot of the therapists wanted to kind of capture your business, but with Medicare, you have a limited amount of rehabilitation afterwards. But I think to maximize the amount of therapy you get, I think it's great to use home health care because it doesn't count towards your outpatient therapy. So you have home health care coming to your house. We've complemented that with some exercise that may give you the app-driven or otherwise. And then once you feel like you can't justify home health care, then you go to their office. So by using home health care, it supplements that outpatient therapy. So there's different ways to rehabilitate yourself that use all of those things. Things we tell you, home health care as well as outpatient.
Okay, so one more question.
How much instruction will you be receiving before you feel confident about using this?
Good question.
I think we all trained on. You train on. We're not using techniques that we're not familiar with. It's basically the same procedure. You're using something to confirm that you're making cuts at the proper spot. So it's not, I think training, do you get more efficient? You can do it quicker, feel more confident? Do it? Yeah, the more you do it, the quicker you may be, but it's usable right away. It's not like you have to do 100 of these cases. So you're doing the same case, just like he was describing the 4-in-1. There's a block that we use right now. It's the same thing. But those first 2 cuts are key. And then we go off those 2 cuts, and the rest of the surgery is just the way we always do it.
It's like building a house. If you have a good foundation, the rest of it can be a little easier. But like Paul said, we're still using basically the same instruments. If the robot dies, we just go on from it. Now, other technology is more like a Dremel machine where it's robotic and they're cutting, and if that power goes out on that point, you're in trouble. So basically, it's some sort of basic cuts, the foundation, and then we're still only checking it anyway.
I was just wondering how you make an assessment between, I've heard from people who've had hip replacement solve a knee problem, or vice versa. So I'm wondering if there's an assessment that you guys run checking a hip versus to see what might actually be the problem if it's not a fully arthritic.
So if you have arthritis in both joints?
Maybe.
Because a lot of times hip arthritis we felt in the knee, and then you look at the knee, and you also have arthritis there. You could try an injection of local anesthetic in one or both joints and see if it resolves the pain in both areas.
But have you had situations where you've replaced the hip and it solved the knee problem?
Yes, even when they have arthritis in the knee.
Thank you.
Your hip, if you have arthritis in your hip, you feel it in your anterior groin, and it goes down the inner thigh to your inner knee. The outside of your hip, like your buttock, there's a little ball there not a ball, but it's a prominence of your top of your femur, your buttock muscles insert on there, and then it has a little bursa sac there, and then you have this big, long IT band that goes down to your knee. That gives you pain on the outside of your knee. But the pain in the front, the groin, almost always goes in the inner thigh, and generally almost all the way down to your inside knee. So you get fooled.
I've had at least 2 patients, if not more, that have broken their hips, gone to the ER, convinced that they had knee problems, had their knees tapped by the ER doctor, and then got sent home. And then they completely displaced their hip fracture, and then went back, and then it was diagnosed. Had at least 2, same story. So convinced that hip pain was really knee problem.
Okay, thank you all. That was really our VP of Philanthropy at Arroyo Grande, just to, we have some closing comments and a closing.
Thank you, Sue. Thank you all so much for being here with us today, and thank you to our surgeons for being here. A couple of things I wanted to talk about our fundraising campaign and how we're going to get this robot at Arroyo Grande Community Hospital. Before I do that, I wanted to talk a little bit about what it means to be a nonprofit. As I'm hoping most of you know, Arroyo Grande Hospital is a nonprofit. We are the foundation, which is the fundraising arm of the hospital. And the difference between being a for-profit hospital and a for-profit hospital is that we don't have shareholders that we pay out. So any profits that are made go back to the community and back into the hospital. So that's part of the difference. We have an operating grant from Common Spirit, which means no donations are used for our overhead. So if you give us $1, full $1 goes to where you designate. So that's a big difference between our foundation and others. So philanthropy does definitely move the needle. So for things like this that would take a little longer to get, the robot, we can get so much quicker if we're supported by the community. And then lastly, there's so many different ways to make a gift. You can make a pledge over a number of years and make payments. You can give through your estate, through IRAs, so many different ways, and we would love to talk to you about those. So the total cost of the robot is approximately $600,000. To date, we have raised $410,000, so the gap is $190,000. This is a video that we've put together that's a compilation of both grateful patient donors and some of our board members.
You know, I think about how healthcare has evolved over time. This came about because one treatment, one discovery builds upon another, and that only happens when we can support innovation, when we can support research. You have to pay people's salaries, you have to pay for the equipment, you have to pay for the infrastructure that lends itself to that. Philanthropy has to play a part in that.
And the quicker we can raise the funds for the technology we need and the improvements we need, the quicker this community will benefit from those.
As a teacher, I see future generations constantly going through my classroom, and I want them to have the best health care they can.
One of the most beautiful opportunities you have is to give back to your local community hospital. We all know we'll be impacted by our local hospital in some way, some shape or form. However, being able to provide a better landscape for that experience in the future is absolutely a legacy that you can be proud of.
Every dollar that's donated goes directly to where the donor designates. So there's no overhead costs taken out of donations. And truly, every gift, large and small, are so important to us and make such a difference. It truly takes a village, and in this case, the entire community.
You know, Arroyo Grande Community Hospital is truly a community hospital. And if you think about it, without our donors, we wouldn't have been able to expand the emergency department the way we did. And today, the emergency department at Arroyo Grande Hospital is busier than any other emergency department in the county. So we've put that new emergency department to very good use. Additionally, in the last couple of years, we've done a lot of work in our operating rooms to improve all the equipment there with lights. We've also opened a crisis mental health center in Santa Maria, but it's used by all of our hospitals. All of those things would not have been possible without community donations and support.
If we want to have state-of-the-art equipment in our small community, we've got to have some skin in the game, and we've got to support it from a grassroots level and from the community up to get what we need.
Okay. Thank you all so much for being here today. If you have any additional questions, if you want to, we'll be around for a little while. If you want to talk to any of us, some of our surgeons are still over in that corner, and I know Sue is always around and happy to answer any questions you may have as well. So thank you all again.